Good morning, everyone. Sorry, I was muted. Didn't realize. Good morning, everyone.
Good morning.
Good morning.
Good morning. Good morning.
How's everyone doing?
Good.
Good
Good.
stuff. Good stuff. Good stuff. Good to have you with us again. And we're going to be looking at Learning Outcome 2 today with regards to Unit 4. Julia, how are you doing? You okay?
Yes, I'm good. Thanks, Mr. Singh. How are you? How's everything?
I'm good, thank you. I know there was a bit of a confusion at your end, specifically just quickly addressing, because you had joined some of the earlier sessions, and as we knew that we are transitioning to the new version of the course, so you were registered on the new version. And obviously some of the units, as I explained earlier to you on WhatsApp, they have essentially been broken up into a couple of units, although the content is not new. So some part of your communication unit we are going to cover here today, which is totally Learning Outcome 2, as you would see. And the Learning Outcome 1 in this unit is basically person-centered approach. So they have muddled some part of the content up, and the unit is now called, Working in Health and Social Care. So the person-centered approach is the first LO, which is a separate unit, totally, for some of the learners on the course today. And then Learning Outcome 2 is communication skills, essentially some part of that. And then as we go into, this is a new bit, which is the spread of infection. This bit is also new. Care planning is a person-centered approach, and administration of medication in particular is a new bit which has been brought in, into this unit. So there are bits and pieces that you would cover, but I would say it'll be best to do the assignment of the units, because the ones that you're attending with me currently are going to go as per, the new curriculum. So you've done Unit 6 with us, you've done Unit 5 with us, research. This is Unit 4, and I think first two units, Unit 1 and 2, were covered, way back when you initially started, and we did specific sessions, for those units, which is the structure and, overview of health and social care sector, and then principles, values, and regulation in the health and social care sector. So
okay, thank you for the clarification.
So there are no presentations that you need to refer, because what will happen is when you do your assignment, you'll end up bringing in some of the content which is from the communication unit, which ideally I wouldn't want from a point of view of you studying this unit. So bits and pieces is what they have, I would say, muddled up. Not happy with it. I've raised it with ATHE, but I think keeping in mind there are some contents which are new, which are more, and this is for everyone. There are some content which are new, obviously, and which are more in tune with what the unit needs to be, or the content of health and social care needs to be in the current context because of the COVID pandemic, the care planning which has to be done, and how the administration of medication to the patients as a practitioner, as a care worker, has to be done, is included now in these units. So what we'll do is we'll make a start. I've got about 10, 11 learners which have come in. If as and when the others come in, we will include them in. But without further ado, let me just press record, and then we will get on with this particular discussion. So thanks again for joining today, and we are looking at, obviously continuing on our bit of journey that we are doing for studying this particular unit, which is working in health and social care. Everything is health and social care that we are studying. So this word gets a bit abused, overused. So I try and avoid, mentioning health and social care or health and social care sector in particular. One of the other things which I would also say is that most of you who are reading this course with us, should get into the practice of using the word called practitioner. The reason I say is, whether you're a healthcare worker, assistant, you work as a healthcare professional, you work within a surgery, you work within a hospital, you are associated with directly or indirectly any sort of care that you provide in a care setting, which could be a care home, nursing home, old age home, nurseries, things like that. People who basically work within this sector and observe some of the legislation, policies, procedures, and actually provide support and care to patients, clients, customers, which are, receiving that care, are all termed as what are called practitioners. So you are basically somebody who's observing the key, let's say policies, procedures, legislation, acts, laws which have been set, and all of you basically use them to provide and implement them and use them, and then provide services to your clients, patients, customers when we are, providing these services within our place of work. So generally speaking, people working within the sector, when I would say there are, and I think some of you, Farida, for example, would remember that there are 350 different types of professions that you can have within the National Health Service, or within the health and social care sector. So people who work within the sector directly or indirectly and are observing some of these policies, practices, they would be termed as practitioners. So obviously, you are a practitioner. That means you are a practicing nurse. You are a practitioner because you're an occupational therapist. You're a practitioner because you're a physiotherapist. You're a practitioner because you work in a pharmacy, and you're the pharmacist on that day. When we go to some of the pharmacies in the UK, you're a practitioner because you're a healthcare professional. You do your shift, or you provide care to patients. You are a practitioner because you are working as a healthcare assistant with a nurse or a clinical nurse in a surgery in a hospital. You're a practitioner because you work within the ambulance and emergency services, A&E. So people working within this at times can be referred to as practitioners, and they would be, that would be a suitable term. Now, going into something that we are covering in this particular unit. So the first learning outcome, if I do a quick recap, was more focused on understanding what is person-centered approach, the 6 principles of person-centered approach, why putting people first has been brought into as the core philosophy of working within the NHS in 2007, led to the creation of the NHS, Constitution of the NHS Act of 2010. And then what are the basic policies, procedures that you observe when you implement these 6, 7 principles? Initially, I think we started off with 6, now there are 8. And these principles that you practice are basically, requirements of one, legislation, second, requirements within a particular health and social care setting. It is to look at safeguarding, and it is also to look at mitigating risks which patients can face when you are actually providing care. Now, in addition to this, in the first learning outcome, we discussed what is called the 6 C's of care. That means when you work within the sector, you have to be caring, compassionate. You have to make sure that the care being provided is safe and effective. So the 6 C's that we discussed were part and parcel of the first learning outcome. And the last part was to look at demonstrating the person-centered values that you can put into practice when you go to your workplace. Now, in the second learning outcome, so we covered this in 2 parts. We did a person-centered approach as one session, and then we did the second session as part 2 to cover the learning outcome 1. Now, today's learning outcome also has a lot of assessment criteria, but it's a simple one because we all know what is communication. So although I have 37 slides or 35 slides to go through, but I think a lot of you would be able to participate by bringing in your ideas, and obviously we'll be able to do some discussions, hopefully, with regards to understanding how to use effective communication in health and social care. There are 5 assessment criteria, 2.1 to 2.5. There is 1 on merit and 1 on distinction, which is basically looking at elaborating on the role of communication in health and social care. And the merit one talks about when we know what is the role of communication, we need to look at evaluation and how it can help influence one of such factors, which is a central principle of person-centered approach, which is confidentiality. So we'll be looking at doing a bit of evaluation on that. And then the distinction criteria also is in evaluation, which is basically looking at how do we overcome barriers in communication. And we'll understand what are barriers, and then we look at how do we overcome barriers. So I will switch you over now to the presentation, and what we'll do is do our discussion using the PowerPoint slides. These would then be available post the session on Moodle, and the recording primarily through the YouTube channel. Now, a fair bit of content to be covered. There is lots of bits that we know already, and what we are going to do is do a bit of refreshing in terms of understanding what is communication, and let's say what are the ways through which we communicate, and what are these specifically in the case of health and social care. I'll take on some questions which you are asking through the chat route as well, which is absolutely fine. So there are 6 units to study, and there will be 6 assignments to submit for the course. So 1 assignment per unit. Now, one of the first things that we want to look at is we know what is communication. Communication, as I understand, if I bring something across, from Google quickly, communication is a process. It's a process wherein there is a sender and a receiver. There is somebody in the middle, which could be technology. But at the end of the day, what will happen is when I send something over, from a point of view of a message, we are using Zoom right now to do the session. So I'm using technology, which is helping us do a bit of communication, primarily on the side of, using this as a process. So when I look at communication, this is what I would say it generally tends to be. You have a sender, which is me. You are the receiver, the learners on the other end. In between, there's a bit of encoding and decoding happening because of the use of technology like Zoom meetings. So the message is being communicated through video, audio, and it is going across to your computer screens. And when you ask me questions, when you give feedback, when you raise your hand, or when you say that, okay, can I ask a question, or you raise a query, that is the feedback that I'm getting, and that tells me that what I'm saying is being understood, and what I'm saying is making sense to the user who's actually receiving this on the other side. Now, this is a generic part, which is communication. What we are focused on in this unit is effective communication. So when we talk about effective communication and effective communication as a process, here we are talking about the process of exchanging ideas, thoughts, opinions. It could be knowledge, data, information that is being communicated amongst colleagues. Because what we want to do is make sure that, like I'm being your teacher and you're on my other side, my being student. So what I'm trying to do is do an effective communication with you to try and make you understand what are the contents of this unit, how to address some of the assessment criteria. And our discussion is a meaningful discussion because it is making sense, or doing this discussion through the exchange of ideas, thoughts, opinions, and information and data using PowerPoint slides, or the verbal communication I'm doing. Now, in the context of health and social care, when we have communication which happens between care workers or practitioners and people, which is patient essentially, who are receiving the services, then we would say, and if they are able to understand each other, then it will be effective communication. A simple example where the communication might not be effective is if I speak English and you understand French. So if I'm trying to speak to you in English and explain the condition that you have, and you on the other side are maybe giving me a facial expression that you're lost or you're not able to understand what I'm saying, then this communication is not effective. This discussion is not being effective because what I'm trying to show and say to you is not reaching or making sense to you. And in this case, this process is not effective. But yes, so in this case, this would be a barrier. This could be a barrier because language is a barrier. I speak another language and you speak another language. So we need an interpreter in the middle, or somebody who can actually translate what I'm saying to what you can understand, and then it'll make sense to you. So effective communication is all about looking at exchange of ideas, thoughts, knowledge, information, which would be done mutually. So when we look at a care worker and obviously somebody who's looking at participating, or, as a patient, when you're discussing your problem with, say, your GP or your doctor, then you feel a bit more relaxed because he or she is asking you the questions which you can answer. It makes sense to you. They are able to empathize or, essentially show courtesy to you in terms of the condition that you have and ask you questions more carefully, which are more effective to a certain extent, making sure that these questions being asked are, not say, let's say, stepping on your toes. They are not, somebody is not trying to step into your toes, and essentially they are providing you or asking these questions to query some bits of information which will allow them to, say, for example, give you medication, or, give you a subscribe or give you a treatment which will essentially work for you. So this is the bit that would make the communication side of things effective. Now, we also look at this particular picture, which I put in just to bring out a bit of a summary, is to say that, okay, why is communication effective? Because sometimes when I'm talking to you and you're muted on the other side without giving me any feedback, I just think that you're passively listening. That means it's a one-way communication. You're only listening to it because you have to be on the session. And that would mean that, you are a passive listener. That means you're listening without reacting. I like it when you are actually listening to me, but also asking me questions, which allows you to speak, interrupt me, and clarify your doubts and queries. And that would be a process of active listening. That means you are participating in the discussion that we are having on this class or this particular session. So when we look at effective communication, it results from active listening. That means the participants are actually speaking to each other. Sometimes active listening can also be non-verbal communication. You're sitting in a meeting, you're in a room, body language can be used, or the way you interact, the way you sit, the posture that you take, the eye movement, the facial expressions could also be used, and that would be non-verbal communication. Sometimes if anything is not understood, you ask a counter question, that is a clarifying message. You make eye contact. In some cases, you change your tone of voice and the way you're speaking. You suddenly start using hand gestures to say, okay, this is what it is. And that also shows communication. Now, sometimes when you have communication can be done in close proximity because you want the communication to happen between a couple of people and you want privacy. So in those cases, you would generally see you either close the room or close the door behind you when you enter the room, when you have a consultation with your GP or your nurse. And in some cases, when certain tests have to be done, there is privacy which is provided. And obviously, because of that, you would be in close proximity with the person who's actually conducting those tests. So there are various ways through which you can make communication effective. And this is an important part of it, because when we look at making conversations, doing discussions, or having communication with patients in particular, or people who are receiving care, and as a care worker, as a practitioner, when you're providing care, this is the one single songbook or hymn book, which is a common thread that you and everybody, family of the patient, near dear ones, maybe other colleagues that are providing the care which is going to the patient, or the care which the patient is receiving as per the care plan, will all be doing. And this will be communication happening, and that needs to be effective for it to be beneficial for the patient. Now, because communication is quite a broad process, what we will also look at studying this process of communication as we go along, by also discussing some of the assessment criteria. Now, the first one talks about describe the role of communication in health and social care. Now, if I have to put it this way, that when we talk about communication in particular within health and social care, we are looking at a couple of things which are important as far as the whole process is concerned. Now, why is communication important? So let's take a quick situation of understanding communication in health and social care. You say, for example, have a condition. Say, for example, you've had fever and that fever isn't going away. So after you've done your own bit of certain, home treatment, or taking up a couple of medication, and you just generally feel now that I need to take professional help, and you ring up your surgery and obviously try and get an appointment with the doctor. Once you get the appointment, you go and see your GP, and the GP is going to ask you a number of questions. Now, these questions are not going to be like, okay, who won the Manchester Derby? Was it City or United? They might break the ice by asking you one or two questions to get you comfortable, to get you talking. But generally, the questions and discussions in terms of queries would be to try and understand what are the symptoms which are causing this fever, and from what time, or from what such time you've had these symptoms, and the GP is then going to try and diagnose the problem, give you a suitable medication or prescription to do away, or so that the fever goes away. Now, when we talk about this in general, this form of communication is going to be verbal communication, because the GP is asking a few questions and you're replying to these set of questions, and these set of questions that you're replying to would essentially start the process of communication between you and your GP. Wouldn't you agree? Yeah. Now, if I put this picture across here just for reference, I would say yes, you would agree, because at the end of the day, the GP would be asking you a few questions, and these questions, when you answer, would allow the GP to try and put together some sort of a plan or say, for example, a situation which will help him or her understand why you're having this fever. Now, when we see the role of communication in particular, the role of communication, the first part that we've done is verbal communication. So the doctor or the GP has asked you a lot of questions to which you've responded. The GP has asked you about your individual problems and needs. You are essentially providing answers to the best of your ability to understand that question and then answer that question. And in this case, the synopsis or the summary which the GP then has would help him to prescribe suitable medication which will help you get rid of the fever. Now, this part of the process shows you what is communication and what it is involved in as a process in communication. It's a two-way process. You're speaking and you're listening, and listening is also being done because you're trying to decipher the questions, and then suitable answers are being provided to the GP, which will allow her or him to then prescribe you medication. Now, some part of this communication can be non-verbal. Can you think of non-verbal communication which will happen between you and the GP when you're there? Anybody, any idea in terms of what could be the non-verbal communication which could happen with your GP when you're seeing him for your fever? Okay, one of the things could be the GP might take your pulse. So the GP might, ask you to, roll up your sleeve and say, can I just take your pulse? The GP might also look at taking your blood pressure. The GP might also look at listening through the stethoscope and, want to see if you have a chesty cough or if you have any sort of an infection in your chest or in your lungs. And this part would be non-verbal communication, because here the GP would say a sentence and say, okay, can I take your pulse? And after that, there will be a couple of minutes of silence because he or she is actually taking your blood pressure or looking at, observing your pulse. And that would be non-verbal part. There would be some eye contact during that communication. There'll be some gestures, there'll be a touch or a contact, and that would be non-verbal communication. Now that is happening in proximity because you're sitting across the table or very close to on the patient chair next to the GP. Now, there could be other forms of communication which could happen, and they could be use of signs, symbols, references. And sometimes the GP might ask you, can you see that picture and read that for me? Are you feeling a bit dizzy? If you tell him the symptoms are that my fever, sometimes I feel dizzy. So the doctor might say, can you read that poster? Can you read that headline on the poster? And this is where the GP essentially would ask you to look at reading a few signs or symbols just to put some objects of reference to what has been asked as a question and what you've replied in return. Now, there could be alternative forms of communication, assuming I have a bit of a disability and I'm say, for example, I cannot hear well, or I put a hearing in loop, or in some cases, if I'm visually impaired, then I would use the British Sign Language. And these are other forms of communication which could happen primarily when we look at, the health and social care setting. Now, people with visual impairment will use touch and braille in most cases because they would actually feel the object, touch the object, or touch a particular object to read that in braille language and then obviously respond. Now, if you're visually okay and you're healthy, your eyesight is good, but you're not able to hear quite well, then you would use the sign language. And in some cases, I would use certain aids like writing on a paper, or maybe using a translator or an interpreter, somebody who's come along with you as a family member who would basically translate what the thing is when you're explaining to the person, and that person would then relate to the GP or the doctor. So a range of communication methods can be used in health and social care to deal with the patients and understand, obviously their let's say their problems or issues that they have. And these are then the basic bits of communication that we do as practitioners, as healthcare providers, when we are looking at obviously dealing with care patients or providing care to patients. And this tends to be the first part, which is the role of communication. The role of communication is very clear. What is the role? It allows us to discuss. It allows us to exchange ideas, information, knowledge, And this can be important because as a care worker, we have to use these forms of communication to either give or receive information about the care that is being planned for the patient. It could be to provide emotional support to a patient or to the family member of the patient. It could be to also carry out assessment of the individual's care needs. And this would be done through the bits in terms of the role of communication. Is that bit clear now? Yeah. So this helps us understand, the first assessment criteria, which will primarily be talking about the role of communication in health and social care. Now, the second criteria that we look at is what are the various methods through which you can communicate in a health and social care setting. And this is what I've explained partly in terms of verbal communication, non-verbal communication, written form of communication, British Sign Language, use of Braille, for example, or sign objects and symbols, essentially, when we look at, the methods of communication. And this would be ideal in a health and social care setting. So when we look at sign and symbols, what do you mean by sign and symbols? We will be looking at sign and symbols, which could be, sometimes like the British Sign Language. I don't know how many of you have heard about British Sign Language, but when we look at British Sign Language, that could be a sign or a visual way of communicating, with the learner, or in this case, the patient. So when I look at sign language in particular, we are looking at using symbols, gestures to be able to, do this bit of communication, with the patient. Sometimes you would use interpreters, you could use technological aids, and they would be essentially sign and symbols or graphical ways through which you are trying to, communicate with users. So if I put this here, just for the purposes of reference, you would use that. Now, if I give you an example, say, for example, sometimes you have kids that you take across to the surgery or to meet your GP. Now, in order to get their attention, what the GPs essentially do is basically they bring across what are called objects of reference. They will have, normally in a GP's room, you will generally see they have some toys, some, objects which would draw attention of the young patients, which could be children in particular. And sometimes we call them that in order to get their attention, the GP would essentially be looking at using what is called an object of reference, something which catches the attention of the young child. It could be a stuffed toy. It could be, something which is, a toy in general, which is available. And in order for him to diagnose and go through the symptoms which the child is having, he or she might give a stuffed toy or some sort of an object to the to the child which he fancies, and that will allow him to carry out his investigation in terms of taking the BP, blood pressure, and other bits if it is required, and that would allow him to come to some sort of diagnosis in terms of why the child has that condition. So there are different ways in which communication can be done. And if I have to put something across, I mentioned that sometimes you have to look at technological aids. So when I talk about technological aids, what I mean by that is some of you in the UK and in other places have also seen that sometimes have what is called the hearing in loop. That means when you look at, going to the banks, when you go and go to the ATMs in general, if you have disability in terms of hearing, then there is an option wherein actually you can plug in your microphone, and that tends to be allowing you to hear well. Or maybe, there is, when you look at touching the ATM keys, you normally see that there are Braille or, some sort of dotted lines also on the numbers, which allows people with visual impairments to essentially feel the object and the buttons and obviously then do the transaction. So they would be the use of technological aids that can also be used in the form of communication. Now, the use of interpreters, sometimes you would see that, when we look at people not being able to express themselves, and this could be because of barriers, it could be because of, for example, language barriers, cultural barriers, you're shy, you're not probably able to, speak to the person you have some sort of syndrome, for example, a deficit syndrome, which does not allow you to interact or, speak to somebody that freely. So in those cases, you would be using what are called human aids, and they would be interpreters or translators, essentially, who would translate between, say, English to Hindi, English to French, English to Spanish. And because you're not able to speak that language, in some cases, cultural requirements, then you sometimes see in some cultures, say, for example, women are normally accompanied by men, because women, have a veil, for example, in some cases, they're wearing a veil and they do not interact. And obviously, the husband would be doing a bit of interpretation, for the questions being asked by the GP in order to help diagnose the problem or the symptom of, the fever that you're having. Now, these are things through which you are able to communicate. So when we talk about methods of communication in health and social care, we'll have to particularly use and mention these are general methods. On the first slide, verbal communication, non-verbal, written communication. You receive a prescription from your GP, a repeat prescription. That's a form of written communication. You have had blood test and you receive a copy of your blood test report. That is the form of written communication. When we talk about non-verbal communication, I gave you an example of somebody using touch to take your pulse, blood pressure, having facial contact, eye contact. There will be non-verbal forms of communication, and verbal would be when face-to-face, you're having a communication in proximity and the questions being asked are being replied to you by at your end, and they will be journal methods. Specific methods are going to be British Sign Language, which is now officially recognized as a language for people who are having disability on the hearing side and visual side. And there are newer technologies which are being introduced to help use this as a medium of language for communication in health and social care. You have obviously the use of interpreters, signs, symbols, and objects of reference, and obviously technological aids which can be used as a form of enhancing the communication that you do with people within, or when I say patients, within the health and social care setting. So any questions on this, feel free to ask me through the chat route or, as we go along. Now, the third assessment criteria is primarily looking at identifying the barriers to communication in health and social care. Now, there are lots of different types of barriers that we can have when we think of communication. Now, when I talk about barriers in general, there could be barriers which are, I've covered these in a few slides towards the end, I think. Yeah. So when I look at, barriers to communication, I would say there are lots of different types of barriers. Now, if you think of some barriers, if I don't show you this and go back, there are lots of different types of barriers in communication. Now, these barriers tend to be, if you can think a bit more outside the box, what do you think could be the barriers for communication? Anybody?
Now, do you have
any barriers that you think are
language?
Language, yes, good, very good. Language is one of the barriers which is generally seen as a very common barrier in communication. Yes. What could be the other barriers? So language is a key one. What else can you think of could be the other barriers?
When you don't have enough technology.
So sometimes lack of knowledge could be a barrier, if that is the point that you're making. Yes, that could be a barrier as well. So sometimes, you have to take professional guidance and you have to go and speak to somebody because you have less information or no information in a particular field. But think of a situation. So for example, if you go to the GP surgery, what could be the barriers that you face? Think of if you go into a bank, you go into a retail outlet, what kind of barriers that you could face? What could be apprehending you from speaking to somebody in a place when you go and you want to have a conversation?
When you are shy, something like emotional.
That's correct. So if you're emotional, if you're nervous, that could be a barrier. Very good. That is another barrier. So sometimes when you have gone through a situation which has made you stressed, or you have faced stress, then in those cases, sometimes you are nervous and you are emotional and you don't know how to speak, or you are not able to speak. And that could be a barrier. If you're undergoing stress or having stress, that could be a barrier. Disability could be a barrier. Sometimes people don't realize that, people have, say, for example, certain sort of a disability. If they hear, they are able to hear, but they hear a bit more in terms of the volume, in terms of sometimes when we use the word that, I have disability on hearing, but I can hear you if you talk a bit more loudly. So disability could be a barrier.
Other things, I mean, cultural barriers is
Yes, definitely cultural barriers, which is a good point. So, for example, sometimes in certain cultures, you generally see people are not very open to somebody who see or who they are meeting for the first time, the way they would want to express their feelings and explain the problems or situation that they have. That could create a cultural barrier. Language could be a barrier, as you've already said. There are certain common barriers that I can think of is that if there is a lot of background noise, if I'm trying to have a conversation with you, and the place where we sit, we have a national rail line behind our, college building. So here, if I open the window, you'll suddenly hear every 30 seconds there's a train which is passing. And if that would create a noise, and noise will become a barrier because that is an environmental barrier, or noise being in the environment wherein I'm trying to have a conversation. If I start using jargons or acronyms that, there is an ADA model, there is a PTC model, there is a PCA approach. And if I suddenly start talking in acronyms and jargons, that could also pose a barrier because you would not be able to understand what these are, and you'll constantly be, let's say, picking your brains to say, okay, what is the term that he's used, or what is the term that he's talking about? That could be a barrier. Sometimes we use dialect, or we say dialect.
Time also can be a barrier.
Yes,
For example, when you go to GP, for example, if you want to explain about all your issues, then the GP usually says, oh no, you should take another appointment for that because you don't have enough time for that. I mean, look at one thing.
Absolutely, that is also correct, because sometimes what will happen is, if you go in and you start discussing multiple problems, the GP would say, okay, you need to take another appointment. I can only, give you so much time for this particular appointment. And that could also be a barrier from a point of view of time. So essentially, when we look at, barriers, I think the point has been made and everyone's understood that there could be lots of different types of barriers in communication. And these barriers tend to be, time barriers, cultural barriers, language barriers. They tend to be barriers which are related to dialect. That means my accent is quite different. If I look at the Glaswegian or Scottish accent in particular, the use of certain words, they would use, for example, I have bought a new house, so the way they pronounce house, or they would say I, nay, I. So if they are nodding, they would say or make certain impressions. So sometimes dialect can be a barrier. If you have a French person speaking English or a Spanish person speaking English because it's not their first language, you would generally see that this could tend to be, a barrier as well. So there are lots of barriers that we identify when we are dealing with patients in health and social care, and they would tend to be is what we need to recollect here. So sometimes barriers could be, created because of poor communication skills, and they could be, other barriers that we've discussed, and that would help, basically just cover this task. So here the task is identify barriers. So as long as we are able to use a diagram or a picture like this and explain a few barriers, you don't need to do explanation of all the barriers, but as long as we cover some of these because they are relevant in the health and social care setting, they would be okay, and that would cover the task. Now, you can have foreign language. I know there are lots of people which have settled in the UK. Their first language is Spanish, German, or French, but they are in the UK, and it takes years for you to learn a particular language in detail, know the dialect, have a proper grammar, and be able to speak properly. So in some cases, till such time that I'm able to speak fluently a particular language, that could be a barrier. And as long as you can explain some of those barriers, that would be in the context of health and social care would be okay, and that would help complete this particular discussion, this particular task, which is identification of barriers in health and social care. Now, the next assessment criteria talks about describe information handling and recording procedures. Now, one of the clear things that you have to understand, and I'm pretty sure most of you know by now, that in the health and social care sector, we have to deal with lots and lots of information. And information is key because that allows us to understand, the background, let's say the context to a particular problem the patient is having. And in some cases, we also need to create a patient history, or diving into their historical records to understand if they have a family history of having a type 2 diabetes or a heart condition. And some of these conditions could be genetic. And in those cases, it is important for the healthcare practitioners to establish the information in its entirety before any sort of medication or treatment or a care plan is put in place for the patient. Now, when we look at this particular situation of, handling information and recording information, there are lots and lots of things which can happen or go wrong, specifically when you're dealing with information which is confidential and related to a particular patient. Now, if I look at confidentiality in particular, confidentiality, when I talk about as the word or just as a meaning of the word confidentiality, it basically means that we need to be able to state why we need this information. And if we get hold of that information, we need to be able to keep that information private or secret to a certain extent, and it is only discussed or shared with the concerned individual. Now, when we look at sharing of this information in the UK, there is a Data Protection Act which was introduced in 1998, and it was updated and refreshed, and a GDPR version of that act, which is Journal Data Protection Regulation. The implementation of GDPR was passed in the Parliament in 2016. All companies, organizations were given 2 years to comply with this GDPR side of things. And this particular act, when we talk about the Data Protection Act in particular, is the act which is put into practice when we talk about data protection and confidentiality in the context of patient records and patient-related information. So we are going to be looking at referring to all forms of information, which includes personal information about people, their medication, their information about their employment records, their medical history, information about, say, for example, personal preferences, their finances, anything which is related to a particular person and is falling in the personal domain would be treated as personal information. And this personal information has to be kept confidential. And this confidentiality is maintained under what is called the Data Protection Act, because this is a compliance, this is a legislation which all care organizations, care settings have to follow, and they have to ensure that the information about the patient and information about the patient, which is personal information, is recorded, but it is kept in a way which is safe and easily retrievable. But when it is retrieved, it is access to that retrieval of information is also restricted, and people who want access to that information would need to have say clearance to be able to go through that information or get access to that information. So when we talk about data protection, this is an act which obviously relates to confidentiality. This holds any organization which is holding data like passport, say for example, looking at your personal details like proof of address and other things, would need to be signed in with the Information Commissioner's Office, ICO, and that allows them to have those records on file, whether in electronic version or in print version. But this access to these records has to be at a defined at the user access level. And in some organizations, you will also have what is called the data protection officer, and that DPO or data protection officer person, designated person, would basically provide access rights to patients, access rights to patient records to employees or staff who need to get access to it, and clearance will be required before they get access to those records in order to protect the privacy, individuality, and confidentiality of patients' information. Now, it could have sensitive information about your treatment, about your preferences, about your personal information, and this could also be used by other individuals or other organizations. If it falls into the wrong hands, as we use the term, it can be used or misused against you. And that is where this particular bit has to be handled in a professional manner. And this is done using the the legislation which is implemented, and that is in the case that tends to be the Data Protection Act. Now, when we look at how can this information be misused, for example, when you look at an insurance, you have a personal life insurance and you have certain conditions. Now, if these conditions are known to the, say, for example, when you got the insurance policy out, you were absolutely healthy and fit, sorry. And then that meant that your insurance premium or the policy when you're taken out, maybe when you were young, the premiums were lower. But as you become old and there are certain conditions that you develop, and if you are prone to certain genetic conditions like overweight, obesity, heart problems, type 2 diabetes, or any sort of a genetic disorder, then your health insurance premiums go up. Now, in those cases, if this information, which is with the GPs and with the surgery that you're registered with, falls into the hands of insurance companies, you would see your premiums rise steeply. So in this case, the GP surgeries and the hospitals or wherever this information is residing has to be stored in a confidential manner, has to be stored in a safe manner, and has to be kept confidential, and it cannot be disclosed to certain agencies or organizations unless they have proper authorized access to it. And in those cases, when access has to be provided, most organizations have what is called the access policy. A data protection officer or somebody who's designated would then provide the clearance, and then the access to the user will be provided. And sometimes some information can only be shared on a need sharing basis. That means if the GP wants to look at the medical history of a patient, or a nurse wants to look at it, they would need it because they want to prescribe a new medication, but they want to look at if you're allergic to a certain type of medication or drugs, then they would need to access your historical records. And in those cases, they would need to get access to that information on a need sharing basis. Sometimes some treatments, when they are provided to patients, would require practitioners to refer to previous medication or medical history, and in those cases the information would be shared on what is called the need sharing basis. So when we talk about how information is to be handled and how recording procedures or access, user level access has to be provided, we need to look at falling back onto Data Protection Act, which is a regulation and legislation in the UK. We need to also look at things like the Human Rights Act. So sometimes information has to be disclosed to family members of the patient because the patient is incapacitated and maybe cannot make a decision. So in this case, the information has to be shared with the family members, the near dear ones, so that they can make an informed decision on the basis of information being shared by practitioners. And that is done in the best, rights or in the best interest of the patient, who currently may not be able to make an informed decision. And in those cases, you would generally see the information being, shared on a need sharing basis. So any questions on this so far? Right. Now, if we go across to the last assessment criteria, which is 2.5, it talks about explaining the principles and practices related to confidentiality in health and social care. Now, here, we need to understand why is confidentiality important, because it refers to information which is personal to the patient, and it has to be treated with, due care has to be taken before this information is divulged or disclosed to anybody. That is where we need to ensure that, a patient's individuality, dignity, and privacy are not compromised. So in those situations is where we say, we need to look at, practicing the principles of confidentiality, specifically related to providing safe and effective care in the case of patients. And information which is personal to them, which could be personal information related to their culture, their beliefs, their values, it could be previous treatments, previous medical history, or family history for a certain condition or a type of condition. They would then be needed to be treated with, with respect and dignity to ensure that this information is used and is provided or shared with only the individuals which are required to get access to this information. And that would be used primarily for the purposes of providing or putting together a care plan for the patient, which allows them to get better or get well soon or get back on their feet as soon as possible. And that would be the context of maintaining good practices for ensuring confidentiality in the case of patient and patient-related information. Now, when we talk about confidentiality, there are lots of different legislations that we have to keep in mind, and some of them we can always say that, you know, the confidentiality has to be maintained, but in some cases it has to be done because there's an act, there is a government policy, there is a law for which which has to be followed in any care setting, and that law dictates that staff is aware, or people who are practitioners in terms of delivering the care or the care plan for the patient are aware of these laws, and they adhere by these laws while implementing or providing care to the patient in a particular setting. Now, one of the first acts or laws that we see is the common law of confidentiality. Now, this is based on the fact that you are encouraging people to come forward with issues and concerns. And if there are issues and concerns related to how information is being shared or how information is being stored, and if the person is not capable enough to understand and take a decision on that particular situation, then in those cases, confidentiality can be overridden, and it can be overridden with the good concern that it needs to provide protection to the patient. One such example that I will put here would be that when we look at in the UK in particular, in certain countries and in certain cultures, obviously, you know, there is more, let's say, preference to having babies which are boys. And in some cases, you know, sometimes you would generally see that certain cultures promote this and they say, okay, you know, we need to ensure that, and there is a lot of stress that is put on to on the girl in this case, and you know, that is driven by culture. But these are norms which are changing in most situations in most cultures worldwide. Now, there is something called, I don't know how many of you have heard what is called FGM. Now, this is a term which is being coined by World Health Organization, and this involves partial or total removal of female genitals, essentially, so that they are not able to have children. Now, this is considered a severe crime in the UK and in most countries, developed countries. Now, if there are concerns that this is something which is taking place, or this is something which somebody is being forced on with, then in those cases, the common confidentiality of law ensures that the person who's being, let's say, forced to, undergo this particular procedure can actually invoke, law, and they can seek the help of the law to bring the perpetrators into, and hold them accountable. So FGM is a training that also most teachers undergo within the higher education setup, and we need to ensure that we are aware of this particular condition. We are aware of why it is forced on, how it needs to be reported, and how do we pick up signs or, let's say, signs of if this is being put in place or is being forced onto somebody, and we should be able to pick up signs and symbols and then report it appropriately under the common confidentiality of law. And this is to keep people safe. And there is a national FGM center in the UK, which basically looks at monitoring this on a countrywide basis. And this is something which is considered a serious crime. And obviously people are prosecuted if they do not, say, for example, report this, and if they remain silent and this crime goes ahead. So in certain cases, when we talk about confidentiality, this has to be overridden because we see a serious offense or a crime being committed against, females, and in this case, girls or women. And that is why in some cases, the common law of confidentiality allows us to override this and report it to relevant authorities so that this crime can be stopped and can be avoided. Now, in other cases where we talk about Human Rights Act, we talk about the CARE Act. These are two other legislation or government regulations which have to be followed in the UK and in most countries when we look at, information being kept confidential. Now, here is where we would look at in Human Rights Act, there are 13 articles, right? I won't go into details as of now, but if somebody wants to read the Human Rights Act, I will put a PDF document on Moodle. Now, there are 13 articles in the Human Rights Act, or HRA, as we call it in short. And this act basically, allows individuals to make, decisions. It allows them, sometimes you hear the term, it says, I know my rights, and sometimes in situations of conflict or in places wherein you feel that you are being impinged on from a point of view of, being put, or you're coming under pressure to do something which you're not wanting to do or you do not agree with, then in this case, sometimes you say, I know my rights. So in this case, what we are looking at is from a context of health and social care setting, every individual has the right to their respect, their individuality, their privacy, and their family life. Now, you cannot override these, basic, I would say, rights for an individual. And in some cases, if the person says that I want to observe my human rights and I do not want to discuss this, or I don't want this to be disclosed, then in those cases, generally you would see that under this particular act, confidentiality and information under that act could be not disclosed. But sometimes, again, we need to understand that in some cases, when we look at human trafficking happening, we look at people reaching, or coming to certain countries and they are being trafficked. Then in those cases, it allows us to also override and report these as crimes so that due, let's say, process or the legal recourse, in this case, for example, could be taken and people could be saved if they are being trafficked against their own will. The Health and Social Care Act of 2012 and 2014 allows caregivers to use the PC approach, the person-centered approach, and also look at safeguarding when they're dealing with vulnerable adults or children. So here, the Act actually states that if people feel vulnerable, they feel, they feel that they are being threatened, they feel that they are being, say, harmed, or they could be physically harmed, emotionally harmed in any way, then in those cases, we say people are vulnerable. And when we look at the CARE Act of 2014, information relating to people who can be vulnerable to certain situations, then in that case, this act allows us to override confidentiality and then report it to relevant authorities so that the person can receive due care, or obviously, receive support essentially from authorities. And in some cases, we have to share the information in the benefit, for the benefit of, the individual or the patient in this case. So when we in general talk about some of these acts, what we are looking at is, I've created a few slides, and the reason I put this across in detail is that, the reason that we want to say is that in some cases, when we talk about, confidentiality and practices that we have to observe, they are because there are laws and there are regulations in place which we need to adhere to, and they sometimes can be overridden in the larger interest of safeguarding the individual, and they can be used to override and then share information in order to prevent crime, in order to protect the individual as well. And these are the four basic laws that we need to be aware of when we talk about practices and principles relating to confidentiality in health and social care. The Data Protection Act, the CARE Act of 2014, the Human Rights Act, the Common Law of Confidentiality Act. As long as you're aware of these, then you can put them in practice and you can actually, inform relevant authorities and observe this. In some cases, if you feel that the patient is not vulnerable or is not being threatened, is not being harmed, then we need to look at observing these laws to ensure that information, privacy, and dignity of the individual is maintained and is maintained with regards to the patient's, will and rights. Now, if I go into, the merit assessment criteria, we are looking at evaluating the, factors which would help us in maintaining confidentiality in terms of information about the patient. So when we talk about basic rules of confidentiality, there are 5 rules that we need to be aware of. These rules tend to be that when we take information about somebody, we need to ask consent that we are going to be taking this information. Do you recall a situation where you see consent being taken before this information is, taken from you? Where do you see this consent being taken from you? Can you think of a few examples?
Charities, organizations that provide services, usually they take your consent.
That is absolutely correct. So in some cases, when you fill, if I make this a bit more generic, when you fill out information in forms, feedbacks, questionnaires, surveys, you will generally see a box which you have to check or tick to say, are you happy for your information to be shared with advertisers or with our associated companies? And do you agree that this information could be then stored on records? And this is where you are seeing the organizations who are seeking this information taking consent from you before they start to electronically save, archive, or have this information stored on their servers. One other such thing which I would put it this way is that generally when you visit the websites now, you would normally see a consent or a cookie consent which normally comes up, and it says, this website would like you to accept cookies. So because we are browsing, we are using the internet lots more than we used to do, and we are looking at information in different ways and forms. One such way that you see website asking you about consent is that they ask you to consent that this website will save a cookie on your machine. That means they're trying to get access to the basic information and they are asking for consent. Now, other rules which are confidentiality rules include things like safeguarding. So the reasons why we basically seek also consent and also try and gather this information is that we want to safeguard individuals, specifically children who are under the age of 16 who can't make decisions. Parents are consented. Their information before it is shared or accessed, would be the consent would be taken from the parents. If you have people who are vulnerable, who are disabled, who are, say, challenged because of disabilities, and in those cases, this consent is generally taken from family members. This is primarily also to share with them the safeguarding procedures which are required to ensure that information being provided, data being collected, is then going to be relayed back to you, which will allow you to make an informed decision rather than somebody else making or taking the decision in your on your behalf. Then you're also looking at records which can be accessed. So sometimes when I, want my information to be removed, I can write to a particular organization and say that I'm not happy with you to store my information. And you can write them to say, please delete my information or remove my information, from the system. And when we talk about the National Health Service in particular, you're looking at this information, being saved or stored is because in some cases it is required to know and preserve the medical history or records of the patient. So in this case, this information should be stored safely. It should have user access limited, or it should be access driven on the basis of need sharing basis. This information should be available, and this information should be protected and should be anonymized in some cases when it is used for research or generic purposes, which will help research and bring out, say, for example, better medication or treatments when it is being used within the National Health Service for improving their processes, policies, and the procedures that they implement within the organization when they are providing care. Now, we could also be looking at protecting information. So this particular task is talking about evaluation. So evaluation, when we talk in general, when we talk about evaluation in general, what does the word evaluation mean? Anybody? What does the word evaluation mean?
To understand the strength and weakness or good or bad.
Yes. So when we look at the word evaluation in general, what we are looking at doing is we are going to review the information and bring it together to make a meaningful conclusion. And in order to review the situation or the information that we are going to do, you have to present a number of different types of views or arguments to have a meaningful discussion. So because it says evaluate, and what does it say? The factors that can influence and maintenance of confidentiality. So the main part of this task is how do we maintain confidentiality of information that is to be reviewed and discussed in evaluation. Now, this task is related to task 2.5, because in 2.5, we discussed about, what is called, what are the principles and practices related to confidentiality of information in health and social care. Now, in the evaluation part, we are going to be discussing what is confidentiality, what are the key principles, how it is related to health and social care. And then what we are also going to do is basically talk about how this is maintained and, then reach a conclusion. So here, what you'll have to do is explain the meaning of the word confidentiality, look at how it relates to health and social care sector, and then how the information is kept confidential is something that we need to briefly explain, and that would cover the evaluate part. So when we look at patient records, when you go to the surgery, you fill up the form once when you are signing up to the surgery, and that has a detailed set of questions about you, where you come from, your background, your previous medical history, and in terms of any symptoms that you have, any genetic conditions that you have. And that part of the information is then once filled in onto the form is archived with the GP surgery, and they have that record then available going forward for a number of years till you are a patient with that surgery. Now, how is that information stored? It's maybe initially on a form, but later on it is using the front-end staff in administration. Maybe it is converted into what is called a patient information record, a PIR, and a patient information record is then electronically stored on the server or on the NHS IT system, and that record then can be retrieved by using your NHS number and your date of birth by anybody in the surgery, in the hospital, or any of the practitioners who have access to that information or would need access to that information. Now, how do you keep it confidential? Is by following the basic procedures of 5 principles of keeping information confidential. Some is law and by regulation, things like Data Protection Act, things like, having user-defined access and people having the access to that information on a need sharing basis. And that with an example, if you cover, would basically be looking at covering evaluation for this particular task. Is that okay? Yeah. Now, the last assessment criteria here is talking about evaluation again, and this is related to strategies used in health and social care settings to overcome barriers. So this task is related to task 2.2, where we talked about communication methods used in health and social care setting. Now, the 2D1 talks about barriers. How do we overcome barriers? So what I've done is in this task, I've started, before I start doing the evaluation, I've started to look at what are the barriers in communication. So generically, I've listed down a few, and these could be barriers which are barriers related to, things that we discuss, things like noise, dialect, culture, language, use of jargon. They are basically barriers which we face while communicating with, people. Now, if I be very specific to health and social care, communication in terms of time, as you had mentioned, Farida, earlier, you go to the GP and you have lots of problems to discuss. The GP says, I don't have time for so much discussion. You might want to take a separate appointment. And that could be a barrier in context of health and social care that we get to see more or less quite often when we go and visit our doctor or seek an appointment with the GP. Language, culture tends to be a barrier, and sometimes communication itself tends to be a barrier because I'm too stressed or I'm too shy, or I am, say, for example, having a lot of problems which are emotionally causing me distress. And sometimes this does not allow me to communicate that openly or in a fair manner that I would want to do with my GP or with the nurse that I'm seeing for an appointment. Now, when we talk about these barriers we need to classify that what are these barriers and how they can affect communication. So here, if I look at figure that I put here, is the one that we discussed earlier. Now, if I have to classify what kind of barriers they would be, there could be sensory deprivation or disability barrier. That means I'm visually not, I have a disability, for hearing or for eyesight, and that could be one of the barriers. Then foreign language and cultural differences. Sometimes you go to places when you see, different posters and written in different languages. So here, this is written in Bangla or Bengali, and you see same notice or a poster written in English. And that is to overcome cultural barriers, which could be because of language or where we come from. Dialect, which I've spoken about, if the accent is very different, you have a Liverpool accent or you have a Glaswegian accent, and that is difficult to understand, or a Welsh accent or an Irish accent, that sometimes could be a barrier. Jargons and acronyms that I've spoken about. You are in distress, you've lost somebody, and it's difficult for you to communicate and discuss your feelings in a greater detail of a loss that you've suffered. There could be health issues, environmental problems like noisy environment and things like that. Now, those are the barriers which we could face in a health and social care setting. Now, how do we overcome these barriers? Now, if you look at sometimes a practical example that I would look at is, think of a situation you're going to see a doctor. Now, if the doctor has to look at your eyesight, or if the doctor has to examine your tongue, or says that, okay, I have a child who has a problem of tonsils and you've taken it to the GP, GP would like to inspect the tonsils. What does the GP do for this inspection at the surgery? Anybody? Can you think of a real life situation? What does the GP do? So the GP in this case would press against, obviously would touch your throat to see if there is any swollen inflammation around, your neck towards where you have your, where you have your esophagus, or, where you have your food pipe, essentially. They would also say, can you open your mouth? They would put a tongue in, and in most cases, you would generally see that GP would actually flash a light, to see, because it is dark. So in some cases, they might also switch on an additional light or ask you to sit on a chair. So if you go to a dentist and the dentist is looking at operating and checking your teeth, or maybe taking an X-ray, so in this case, the dentist would ask you to sit on the dentist chair and then position the chair in a way wherein they can access your mouth, and then put maybe a brighter light to see internally when you open your mouth, and they say, can you open your mouth wide? And using tongs, they would basically inspect, but they would also need a light. So if you look at practical situations in terms of what could be things which are used to overcome these barriers, I could think of a simple example that I've given here is, using bright light or proper lighting in a room in order to look at diagnosing a particular, problem. Sometimes you would see, in order for you to get talking and in order for you to understand or make you understand certain things, there are uses of posters, signs, and certain objects that would be required. So if I go to an optician and I'm getting my eyes tested, the optician would ask you to undergo certain tests, and they would be checking the pressure in your retina. They would be looking at, obviously asking you to look into a machine, read some different types of texts on the wall, look at the posters and see what can you read and things like that. That would be the use of technology to overcome a barrier and diagnose your situation in terms of your eyesight. Do you have a weak eyesight? And in those cases, you're using technology as an aid to overcome this barrier. So when we talk about health and social care setting, sometimes it is about clearly communicating with the person, to ensure that there is enough lighting, and enough room available for maneuverability to be able to do a proper inspection or diagnosis of a problem. Sometimes it could be the removal of background noise. You would generally see when you're in a GP surgery, or if it's too noisy in a hospital, the GP would call you in a consultation room and close the door behind you, because obviously they don't want to be distracted because of the noise which is there, the passing stretchers, the medical staff, the ambulance sirens, things like that. They could be looking at. So in this case, they're trying to look at removal of the communication barriers by looking at reducing noise in the room in which you are going to be asked to sit or come in for a consultation, which is peace and quiet. Now, these are the barriers that you have to think of, which are generally going to be used, or generally that you face when you're trying to communicate with patients, or when you're trying to provide them care. And they would be examples of barriers that you need to discuss in this particular task. Sometimes I would also give you an example, which is the pace at which we speak. Sometimes if cultural English is not your first language, and you still, I still feel a bit proudy, and obviously I say that, no, I understand English. I don't need any translator or interpreter, but I would only request to speak a bit slowly, because English is not my language, or if I've undergone a particular stress or an accident and I'm recovering from it, you might want the pace at which a person speaks to you be altered. So in those cases, pace at which you speak, the speed at which you speak, gestures that you use, sometimes you could use this as an option, and you would say, okay, in order to overcome a barrier of communication specifically, which is because of language, you might ask the individual who's speaking to you to slow down or speak in a bit more clearer tone, but slowly, so that you're able to interpret what the person is saying and then respond back to the query or the question which the person is raising. And obviously technology comes to your aid. We've talked about hearing in loop, and we have talked about, posters, signs, improved lighting, and, reducing the background noise, which is because of the setting that you're in, and that allows you to overcome some of these barriers that we see when we are interacting with patients, customers, people who are visiting you, or are coming to you, wherein they are receiving some sort of treatment or care, essentially from a point of view of health and social care setting. Is that okay? Is that clear? So this particular task will talk about essentially you recapping and summarizing what are barriers and how do you overcome these barriers, specifically related to, by giving an example of health and social care setting. So that brings us to the end of, this particular discussion on Learning Outcome 2. And this presentation, along with, handout on Human Rights Act, if some of you are interested in reading, is going to be available on Moodle. And what I would suggest is that you need to go through these just, so that you get a bit more understanding on today's learning outcome that we have essentially covered. Although I've tried to go in a lot of detail, and this is the only bit on communication that we're going to be studying with regards to, the communication aspect in this particular unit. But if you would want to study a bit more and get into a bit more detail, then the idea would be to also look at some of these sites which I put in as references and for further reading, and they would give you some additional information with regards to confidentiality, the various legal regulations which are applicable in the UK and specifically related to the health and social care sector. So I will see you tomorrow. And then in that session tomorrow, we'll be looking at discussing Learning Outcome 3. So thank you so much for attending. And in the meanwhile, if you think of any questions after the session, feel free to drop me an email, and that should come across to me at learnerwork or litc@learnerwork.ukversity.co.uk. So thanks so much, and I'll see you tomorrow.
Thank you very much. Have a good day.
You too. Thank you. Bye. Bye for now.